Hello, everybody. Welcome Tuesday afternoon for me, but morning. Actually, no, morning. I usually do 12 p.m., but it's still morning. 11 a.m. EST, 8 a.m. PST. Good afternoon or good evening for everybody joining from around the world. It's my pleasure to host Recap VMR, which is a great initiative on CPS to have or allow people, our Academy members, to discuss cases and major points that they've learned from these cases whilst reviewing them. So before we get underway, I'd like to introduce our two Academy members that will be discussing cases. First of all, Magnus Bach, could you unmute and introduce and maybe tell us something a little bit about yourself?
Yeah, thank you very much, Ravi, and hello everyone. My name is Magnus. I'm from Denmark. Currently doing a PhD about infective endocarditis, and I'm very happy to present today.
Wonderful. Really appreciate you putting this together. And then next up, we have the one and only Hans, who's been a member, who has been here at CPS for a long, long time as a viewer, and now recently became a member. So Hans, are you able to unmute and also introduce yourself?
Yes, my name is Hans, and I became a member of the Academy in July. And yeah, a little bit nervous to present, but the case is absolutely fascinating. It goes back to August 1st, and I think you all will enjoy it very much.
Awesome. Yeah. Once again, thank you very much for putting these cases together. Before, without any further interruption, we'll start with Magnus and his review of the case that he's presenting.
Great. So I will just put up my slides. Do you see it in full screen now?
Yes.
Great. Okay, thank you very much. So I'm gonna present the case presented by Vinny and Julia to Rabi and Reza on the 8th of August. And the case started with a chief complaint of a 74-year-old man who presented with low back pain, bilateral hip pain, and difficulty walking. And whenever we see low back pain, this is such a common complaint. And in most cases, actually in about 90% of cases, it's a non-specific back pain, meaning we cannot assign a specific pathoanatomical course to the pain. But in some cases, we can, and we talk about a specific back pain, namely being due to neurological issues, musculoskeletal issues, or a retroperitoneal course. And that's why it's important to figure out which patients we should investigate further. And therefore, we have these different red flags that should prompt further investigation. And these are mainly neurological symptoms like motor deficits or saddle anesthesia. Can also be inflammatory symptoms like a fever or severe weight loss, or a history of cancer that could make this patient prone to metastatic disease to the back. And in this patient with the constellation of low back pain, bilateral hip pain, and difficulty walking, we were considering whether there could be neurological deficits or weakness in the legs. And this could be due to, for example, a myelopathy causing low back pain, weakness, and also referred pain to the hip. So that's why we proceeded with those thoughts. And in terms of the past medical history for this patient, that included severe rheumatoid arthritis with bilateral hip replacement, bilateral knee replacement, bilateral MCP joint replacement, and also multiple revision surgeries due to infections. He also had a history of prostate cancer, and due to rheumatoid arthritis, he was taking methotrexate and prednisone. So from these informations, we saw that the patient is immunosuppressed and also has multiple prostheses, which could be a seed to infections, which he had also had multiple, and he also has cancer. So that also something to worry about in the case of back pain. But another key thing here is that when we see a patient with such a complex patched medical history that could have many, many reasons for complaints in the musculoskeletal system, it's very important to figure out what the cause of the acute presentation is, and also use the history and physical exam to clue us in here. So in terms of the history, turns out he had chronic back pain for 5 years with no acute changes. He also has bilateral hip pain for 10 years, but now with acute worsening in the right hip over the past several months. He had no falls or trauma and no inflammatory symptoms. So with this history, we started to figure that maybe the hip pain, especially in the right hip, could be the center of gravity in this case. And we know that he has a prosthesis in the right hip. He also had recurrent infections, so that's definitely something to worry about. And also, a key thing here is that the possibility of metastatic cancer to the hip is absent because he has a prosthesis, so we can take that off the list. So moving on to the physical exam, he had an episode of fever, but now had completely stable vitals. He also had redness and edema over the right hip with pain of mobilization. He had no neurodeficits, and he had mildly elevated inflammatory markers. So we were definitely still worried about infection with these signs of inflammation here. But interestingly, at an outside hospital a few weeks prior with the same chief complaint, there was performed an MRI and also a joint aspiration of the right hip, and those were normal. But blood cultures at the same time grew Staph aureus. And this was really a turning point in this case. So whenever we have Staph aureus bacteremia, we mainly focus on 2 questions. And those are, where did you come from and where did you go? So talking about the source first, that is usually from the skin. So that could be from a cellulitis or an infected IV catheter, recent surgery. But it could also be from the nasal mucosa causing pneumonia, although that is more rare. But it's also important to remember here that in many cases we cannot find a specific source, and then it becomes much more important to figure out where the bacteria went in the body. And that's where we think about the heart valves. So in fact, 25% of cases with the Staph aureus bacteremia have infective endocarditis, so that's really important to remember. Also, prosthetic material can be a seed to infection, and also the spine in terms of osteomyelitis or joints causing septic arthritis. So those are some of the main sites to think about. And that's why when we evaluate patients with Staph aureus bacteremia, it's important to perform a good history and physical exam, focusing on the sources, but also the consequences of Staph aureus bacteremia. All patients should have a TTE evaluating for endocarditis. And it's also important to repeat the blood cultures to confirm the bacteremia, but also to figure out whether the patient has a persistent Staph aureus bacteremia that has a poor prognosis and should definitely make us worry. And then on the basis of that, we can expand the evaluation, also performing a TEE, which has much more sensitivity than the TTE, or we could perform advanced imaging, for example, of the spine. And then we should manage the patient with appropriate antibiotics, and also, if possible, perform source control, remove any lines or drain possible abscesses. So going back to this patient we should definitely repeat the blood cultures and also perform a TTE. An MRI of the spine could be relevant due to the back pain, and also repeat the MRI of the hip to look for periprosthetic joint infection. So The repeat blood cultures did show Staph aureus again. A TTE was normal, and the repeat MRI at this time showed a large gas-containing joint effusion, and therefore he was diagnosed with the periprosthetic joint infection. So talking about those, they usually present with a painful joint, and sometimes we can see signs of inflammation, but they are not always there, especially if it's in the hip, because that's a joint that's very deep beneath the skin. And often the fever is also absent, so the signs of inflammation can be very subtle or absent. The bacteria that are mainly responsible for these infections are usually the gram-positives, such as Staph epi or Staph aureus, but also Streptococcus species and Enterococcus species are quite frequent. And it presents in different ways. So there's an early type or acute, which usually comes within 3 months after surgery. And those are usually due to bacteria from the implantation of the joint prosthesis. And then there was also this late or chronic type of infection that presents usually much later and also can be due to bacteria from hepatogenous spread. And those can be much more hard to diagnose. They present with much more slow and low-grade inflammation, and so they are notoriously hard to diagnose in the clinic. The blood cultures are positive in around 25% of cases in all patients, in all these patients. And the cultures from the synovial fluid are positive in 50 to 80% of patients. And this really also suggests that there's a large number of culture negative patients. So that's really important to remember here. And the imaging can also be negative. So if we have the suspicion of a periprosthetic joint infection, we should really repeat the tests if they are negative, and we still have the suspicion in these patients if there are a lot of risk factors. And I just pasted in the diagnostic criteria here. And I think what's mainly interesting about these are that the leukocyte count in the synovial fluid are usually much lower, or the threshold for when we should suspect infection is much lower. And that is compared to septic arthritis. And that is due to multiple things, one of them being that the prosthesis in itself does not have an immune system, and also that the bacteria in the joint or on the prosthesis can form biofilm, which causes a much more slow and low-grade inflammatory response. So the leukocyte counts are usually much lower than we see in septic arthritis. I thought that was a really good pearl. And I chose this case because I thought it was interesting, and I think it touched on some really core features of internal medicine, back pain, and Staph aureus bacteremia. So thank you very much for your time, and here are my references, and I'm happy to take any questions.
Wonderful presentation, Magnus, and I'm really glad you chose this. I was present for this case, and very remarkable. So starting, I really liked when you started with the back pain, hip pain, groin pain, and so on. And then you discussed about alarm diagnosis. What kind of things should we think about? So I started looking at what should we think of with such a presentation, because of the, like you said, the presentation of the differential diagnosis is very broad. But I think one thing I learned from this case, pattern recognition is key. When you have bilateral symptoms, it's not just trauma, right? We always think about trauma. I admitted last week a lot of people with hip pain, back pain from fall. falls, syncope, and so on, and you're concerned about trauma, but you have to start thinking about more sinister disease. And then if you think of red flags and bilateral pain increases the likelihood of a dangerous condition, and I really like you started thinking about spinal cord emergencies, which you do need to think about in this case. So these are diagnostic alarms, and it should trigger a signal to work this up and do some imaging right off the bat. Any comments before I go to the next thought?
No, I think that's wonderful.
I think second thing is, you know what's interesting? I was on service last week, and you also mentioned the SED rate and CRP. Orthopedics likes to do that. I don't know in Denmark if they do that quite a bit, but it's a very convenient, easy grab or easy reach test. So what's interesting in this case was like, yes, it's actually very good. It has very good sensitivity, specificity for chronic osteo. But like you nicely mentioned about the prosthetic infection, there's a totally different sort of infectious milieu or environment that's present there with this biofilm and what happens with Staph aureus. And you only need a little bit of Staph aureus to really take up residence on the prosthetic joint and evade the host immune response. And because of all the wonderful biofilm and all the things to escape the host immune system, the inflammation is just minimal in this case, like you had mentioned. So the sensitivity, I looked up sensitivity specificity for SED rate in this case, and it is about 10-15% less than acute osteomyelitis. So it is not that drastically low, but is much lower. So if acute osteo is 90 to 100%, prosthetic joint infection for CRP is 60 to 70, so not as good. And ESR sensitivity is also 60 to 70, so not great because of all the kind of infection. It's totally different kind of condition than acute osteomyelitis, which will trigger the host immune response. Any comment on that, or?
No, I think that's really interesting, and I think in this case it was also complicated by the rheumatoid arthritis. He had many reasons for being inflamed.
Oh, right. You mentioned also the immunosuppressant medications the patient was on. So you're right. That also added to this as well. But I think in future, for myself, for a patient with this condition, I have to think about SED rate and CRP not being as robust, and not to rule out possibly a prosthetic joint infection in this case. And I think that pretty much is it. Any other questions from anybody before we move on to the next case? Yeah, and Magnus, you talked about your specializing in infective endocarditis. So it's key here because, like, I think 25% of infective endocarditis or staph causes 25% of bacterial endocarditis. So that TE is often necessary when you have an infection like this. All right. Great job, Magnus. Really loved the presentation and the teaching points. Excellent job. So without further ado, we'll move on to Hans, who is presenting the next case. Over to you, Hans.
Thank you. And now I start sharing my screen. And just a second. Can you see it already? No.
Yes.
It's there. Okay. And I just make it a little bit tall. Okay. Now my case is from August 1st. And that was one of the most exciting ones. It's a little bit zebra-like, but I think I have a few bread and butter pearls in here that might be interesting. It was a case presented by Nicola, and the discussants were Rabi and Risa. And the patient who came in with a chief complaint was 62 years old, and he presents with sudden dyspnea while climbing stairs. That is, he has dyspnea upon exertion. And this is a hyperacute to acute situation where we are concerned of certain immediate life-threatening conditions, such as an MI, an aortic dissection, a pulmonary embolism, but also maybe a pneumothorax. And one of the really interesting pros, which are actually self-explanatory, but it's important to remember, acute things don't happen on themselves. There is some chronic or past medical history that is leading to this situation, and we should actually inquire into the HPI and the past medical history with great thoroughness. Now, in this particular case, we had a patient who was not feeling well. He had fatigue, weakness, abdominal pain, dry cough, everything unspecific at this point for years. And now, however, he's more out of breath than usual, and he noticed it while climbing stairs. He also noticed a sharp pain in the chest. He says it's non-positional, however, it is getting worse when he is breathing in. It is non-radiating. And the chest pain is the one thing that we are now looking at, and there is the possibility of a central pericarditis, which is, however, positional. When leaning forward, it's better. Leaning back, it's a little bit less severe, but also the possibility for ischemia of the pleura, something going on there from infection to ischemia, infarction of the lung, rupture of the lung into the pleura, here pneumothorax, or hydropneumothorax. And for us in the ER, it means that we should get a chest X-ray immediately. And if we don't see anything, we send the patient right away to the CT scanner and do a CTA, a CT angiogram. No, it doesn't seem to work the way I like. And in his past medical history, the patient now mentions hypertension, actually arterial hypertension, hyperlipidemia. He had 3 embolic events in the last 5 years, and he actually listed them. It's a DVT 5 years ago, a segmental PE at age 55, he's 62, and a portal vein thrombosis at age 61, that is just a year ago. Patient denies any autoimmune diseases, and he says he's up to date with all his cancer screenings. On his medical side, he's on apixaban, so a blood thinner, twice daily with good compliance. So there is no question about that. Atorvastatin is on, amlodipine, and he's taken multivitamins. The family history is unremarkable, except for the father who had a myocardial infarction. Social history, nothing of significance. His physical exam shows a temperature of 108, blood pressure, which is 135/98, which is normal, but a heart rate, which is tachycardic, and tachypnea, and an SO2 of only 93%. So here we get a flavor of lung or heart being involved. The physical exam is unremarkable completely, except for his abdominal exam, where he showed pain and tenderness upon palpation in the epigastric area. He also showed conjunctival pallor, as if he had anemia. So we have now at this stage of our inquiries the combination of a possible anemia, and we have epigastric pain upon tenderness. And the patient is on a blood thinner. And here Rabi said, as a PGY 11, I know that the most likely combination of this might be iron deficiency, that is bleeding of the patient into the GI tract. And this actually was shown coincidentally to be the case. The patient received an EGD and it showed a bleeding ulcer. The labs are basically unremarkable, except for a low hemoglobin, which we probably anticipated from the conjunctival pallor. But standing out is the platelets, which are 74,000. So now we have a patient who is having clots. He is anemic. He has thrombocytopenia, and he's on a blood thinner, in particular on a factor X inhibitor. The next investigations were an EKG, and it showed the S1Q3 inverse T3 pattern, which we identified as a pseudovalence syndrome. And this is very much characteristic of a right heart strain caused by many conditions, amongst them a pulmonary embolism, but also coronary vasospasms, everything transient and reversible, including cocaine intoxication, myocardial bridging, meaning that a coronary artery is being compressed by the myocardium, and sepsis. And because there is a pseudovalence syndrome, there is also a valence syndrome, and the valence syndrome, in contrast to the pseudovalence syndrome, is a very ominous sign. It is a sign in the absence of EKG findings of an ST elevation or troponins, and it indicates an impending MI of the LAD. For completion, because it's interesting to remark, I have the valence syndrome just listened here, the EKG, and there it is, the biphasic waves in V2 and V3, as well as the deeply inverted T waves in the precordial leads, especially V2 to V6. And as an example, I do have an EKG here, and here we see the inverted waves in the precordial leads. This requires probably an immediate visit to the cath lab. Subsequent CT scan, a CTA scan, corroborated our suspicion of a pulmonary embolism. So now we have a patient with a pulmonary embolism, and at that stage, Risa has given us a wonderful program representation of a middle-aged man, 62 years old, with a history of recurrent venous clots, a pulmonary embolism, while on apixaban, in the context of, and that I highlighted in red, thrombocytopenia. And that is so far unexplained. The differential for a condition like this is coming up next, and that would be our antiphospholipid syndrome. This has no extravascular signs, and this would fit very well to our patient. It could be a malignancy. It could be something new, which is the platelet factor 4 disorder, no extravascular signs as well. And for completeness, I have Behçet syndrome or disease, which has extravascular signs like genital and mouth ulcers, and pathogy, which is redness and swelling upon injury with a needle, for instance, or paroxysmal nocturnal hematuria, which we should consider as well, but we have not seen, in anticipation of the labs that are to come, no blood in the urine. So now our standard routine labs, hemoccult test is positive, and EGD, as mentioned above already, we had a stomach ulcer. So that explains his tenderness in the epigastric area. It explains his low hemoglobin and the findings in the PE physical exam. Urine analysis was unremarkable. A flow cytometry was done as well, and no signs of paroxysmal nocturnal hemophilia. Thrombophilia panel was completely normal, blood smear normal, B12 following normal, lupus anticoagulant was normal, but we have to be very critical. The anticoagulant as such was positive, but the patient was on apixaban, so the result could be false. But all the other values, anticardiolipin and beta-2 glycoprotein, normal. And a PET CT was normal, very much in accordance with the patient's statement that he was up to date with his cancer screenings. And then we had a more specialized labs. He got a serum protein electrophoresis done with an M spike of 2.7. He had a kappa lambda ratio of 2.4. He had a platelet factor 4 ELISA hit, meaning that is heparin-induced thrombocytopenia, which is negative. And the investigators went a step further and did a PF4 ELISA-VIT, which is a vaccine-induced thrombocytopenia. That one was positive. Also positive was his serotonin release assay, indicating activated platelets. And then bringing about the proof of our diagnosis was a mass spectroscopy. A kappa light chain of the isolated PF4 IGs matched the M protein from the peripheral blood. And this was then the rather rare but interesting diagnosis of a monoclonal gammopathy of thrombotic or thrombopenic significance, and that one caused platelet factor 4 disease. Very interesting at that point is the treatment. We are usually more interested in diagnosis, but treatment is really something we should be very much aware of. Patient was switched from a factor X inhibitor to a thrombin inhibitor. Then, in order to suppress the reaction, he was given IVIG, which blocked the receptors on the platelets. And then, in view of his MGAS and the MGAS in association with symptoms, he was given a treatment that is given normally in multiple myeloma, a triple treatment of daratumumab, an antibody against CD38 on cancerous B cells, bortezomib, which is a protease inhibitor and prevents production of antibodies, and dexamethasone. And with this, I would like to briefly conclude my presentation by summarizing the beautiful cartoon that Nicola has presented to us during his presentation. PF4 is a chemokine and it is stored in alpha granules within platelets. And when those platelets get activated, either through injury or in our case with antibodies, then PF4 is being released, and PF4 is a positively charged molecule or protein, which binds molecules or proteins that are negatively charged. And an example is heparin. And upon injury, those antibodies or injury or antibodies that are binding to our platelets, like the receptor Fc gamma receptor, activates the platelets. The platelets release PF4, and PF4, as Nicola so nicely showed, is a glue that glues the platelets together. The platelets form a thrombus, which is then further stabilized with other processes. So how can we get hit? The classical hit we get when patient receives heparin, and in the presence of PF4, this forms a heparin PF4 complex. This complex undergoes a conformational change and is being recognized as an epitope by certain B cells. Antibodies are then formed against PF4 heparin complex, so always heparin is present. And these antibodies can activate the platelets, that is, they have the right constant factor that engages the receptor on the platelets, or they don't. If they do, these antibodies are termed by some investigators as anti-PF4 type 2 antibodies. If they don't, they are being referred to as PF4 type 1 antibodies. And the type 1 antibodies is what most people have in their blood, but rarely the anti-PF4-2 antibodies. In that case, we have to stop heparin immediately, and the reaction comes to an end. But when the patient develops VIT, then it is not heparin, but it is other complexes. And the complexes it was first observed was from the COVID adenovirus vaccine. And it is the adenovirus membrane that causes the complex between PF4 and the negatively charged molecule, which then acts as an epitope. And this then gives rise to heparin-independent antibodies, referred to as type 3, which have exactly the same effect as HIT. However, these antibodies bind to platelets at a different site or a slightly different site than the hit antibodies. Therefore, hit ELISA can be negative, while VIT ELISA is positive, as in our case. Now I would like to present one more slide where we have something like beyond autoimmune hit, which is beyond hit is autoimmune hit or the spontaneous hit. We have a situation where a patient might just transiently get in contact with heparin or with substances which are heparin-like and forms antibodies like before, but antibodies which are independent of heparin. These are called type 3. They are induced through a heparin flush or low molecular weight heparins, or in case of a total knee replacement, by body-like substances, dead cell material that is being released during the tourniquet that has been on for an hour during the surgery. And the spontaneous hit then gives rise to hit while the patient is exposed to heparin, but it persists upon stopping heparin. And we also have a spontaneous VIT, where the patient develops a vaccine-induced thrombocytopenic thrombosis, and that is exactly our MGCS, monoclonal gammopathy of coagulation significance or thrombotic significance. And everything that I just said has been summarized by Rabi in his schemata, PF4 disorders. And we see nicely the spontaneous here, the trigger, the orthosurgery, then post-infectious, and MGAS is down here. The features are DIC-like. Then we have the classic one, which is the heparin-induced. We have the autoimmune, which is related to our vaccine. And with this schemata, I would like to conclude my talk. And the literature that I use is right here. And thank you very much for giving me the opportunity to present this case.
Wonderful job, Hans. Very complex case with many layers. What was really interesting for me, this is something I haven't seen before. I don't know, Magnus, have you seen this condition before, read about it? It was definitely an eye-opening or a mind-opening case for me. But the one thing I do see when you went through the case was the patient has multiple thrombotic events, right? So history, which was a alarm feature of this case. Second thing was then the patient is on a Pixaban. So the problem here lies in that if you introduce this bias that, okay, the patient is on anticoagulations, so therefore cannot have a thrombosis, you immediately could miss a lot of conditions that can happen. So the conditions I usually see is non-compliance, weight can be an issue, absorption can be an issue. Other medications could impair the absorption of this as well. So drug-drug interactions. And other things could be breakthrough clot on apixaban. So you have people that won't take it or cannot resorb it, or you have people that take it and then they develop these breakthrough clots. So there you have to consider more common things, sometimes malignancy. Some malignancies can be very thrombogenic in this case. Then antiphospholipid syndrome. The treatment for that is an apixaban. It would be warfarin in this case. So in this case, one junction where these tests were done, they were negative. So then you had to move on further. Other PNH you mentioned was key as well. I learned in this myeloproliferative disorders. HIT you mentioned, of course, nephrotic syndrome can also be a hypercoagulable due to urinary loss of anticoagulant, protein C, protein S, anticoagulant proteins. And then comes this MGTS, which is something I'm like, I definitely have this takeaway from your case, which is very significant. And you did a wonderful job in describing the mechanism of that. Any questions or any other comments, Hans, before we wrap it up?
No, thank you very much for your comments to consider more common things like drug interactions. Non-compliance was excluded, but difficulty absorption and then the breakthrough clot due to other underlying diseases, malignancy being one of them. And of course, a disease that is being treated with apixaban, but in reality has APLS, which requires warfarin.
Awesome. And thank you for the explaining the EKGs. I think you did a wonderful job on that as well. The Wellens and pseudo-Wellens. So fabulous job. All right. Thank you, Magnus. Thank you, Hans. Wonderful job. That concludes today's recap VMR. Make sure to tune in tomorrow for another VMR, I think at 12 p.m. Take care, buddy. Bye.